So I'm just going to add, my name is Ricky Chen, and I'm a neurooncologist in Providence, Oregon. So I'm just going to add a case to the discussion that I think was interesting from a clinical perspective, how every day we're going through treating patients with brain tumors and we come across diagnostic dilemmas and therapeutic decision-making, and how kind of in our still growing armamentarium, we're facing still large gaps in terms of making the best decisions for our patients. And I think molecular profiling is filling that gap to a great extent. This is just a case to kind of show you the journey as we go through some of these patient diagnoses and investigations. So I had while I was in the hospital, there was a case of a patient who was 65. She's had a long-standing history of relapsing remitting multiple sclerosis, with gait difficulties, neurogenic bladder, and a number of other issues, but still doing relatively well, and her MS was fairly well controlled despite being very non-compliant on her Copaxone injections. She also had a complicated history of other situations, other comorbidities with COPD, hepatitis C, that had been treated and had a negative viral load just a year ago. And she came in because of a couple months of progressive confusion, dysarthria, and what were considered facial muscle spasms. But when I actually talked to her in the hospital, it became clear that she was actually having facial seizures. And her workup at that time, because of her underlying history of multiple sclerosis, she was given Solumedrol, but continued to worsen. And then in an attempt to get better control over a presumed MS flare, she was given Tysabri, which we know is a very potent anti-demyelinating medication. And but however, even with this, on follow-up scans, there was enlargement of her lesion, and I'll show you the imaging. But her laboratory workup also included HIV and LDH and JC viral loads and CSF, which are fairly unremarkable. I'll come back to kind of tell the story a little bit, but here's her imaging where we see in the frontal lobe there's a enhancing lesion, and this was what originally was felt to be perhaps a tumefactive MS. It's a little bit unusual to see so much edema around it, but there was also, the picture also suggests after she got Tysabri, the question of PML came up. And so we used some of the tools that were discussed today with MR spectroscopy and perfusion. And what we saw is that in her spectroscopy, we saw the normal NAA levels and choline and creatine levels were not fitting with a tumor. There was a lactate peak, however, that could be consistent with multiple sclerosis or other kind of necrosis. However, when we saw that in follow-up, her lesion grew despite this aggressive MS management. We went and got a perfusion scan, and it did show hyperemia. I think the RCB values were in the 3s. So it showed increased blood flow into that region, which favored neoplasm over MS. So you can see that even with all these tools that we have as neuro-oncologists, we're still having difficulty with conflicting information and how to even decide in this case, how to manage this patient. And in this case, let's see, so in this case, the differential diagnosis from that imaging included tumefactive MS, glioma or primary brain tumor, metastasis, lymphoma, and PML. So it was very broad. And this patient was getting worse despite Tysabri. She later ended up getting plasma exchange, again to help against the MS, but also with the thinking that perhaps she now has PML, given that she had mildly positive JC virus titers. So she went through that as well, but continued to decline in the hospital to the point where she went into the neuro ICU. So further workup in this case, we did a lot of imaging to look at her staging to see if this was a metastasis, and we did not find any clear evidence of a primary cancer from which that could have spread up to the brain. PET imaging also showed fairly nonspecific findings with a mild to moderate uptake in a non-enlarged left hilar lymph node. Although it was suspicious, it didn't really help make a diagnosis one way or the other. Again, I discussed the spectroscopy and how there were conflicting findings. So this patient went to undergo a brain biopsy, and it did show that this was a metastasis. It was a metastatic adenocarcinoma that was poorly differentiated. This is a worst nightmare for neuro-oncologists. We don't know at this stage where the cancer is coming from. So without a primary cancer diagnosis, it's very hard to decide whether the patient gets chemotherapy, radiation regimen, what have you. And there was mention of staining with using immunohistochemistry in the pathology department, try to determine what were likely candidates for the primary. They raised questions of breast carcinoma and also a GI malignancy, upper GI tract. And so we did some further, with that, she underwent a resection for that, but also followed up by gamma knife to treat the brain metastasis, based on the information that brain metastasis will respond to focal radiation regardless of the primary source. So that was given to her. However, on follow-up scans, we see that she had new lesions. Some of these are periventricular and has a question of whether the MS has come back. And then there was a cerebellar lesion that did grow on short-term follow-up imaging, so we know that that was a metastasis. So the story is kind of evolving, and as we continued her workup without a primary source at that point, we underwent multiple exams. And mammogram was done, which was negative for that suspicion of a breast carcinoma. GI consultation with EGD, ERCP, looking at the pancreas, and a GI lesion was also biopsied and negative. She had skin exams for melanoma, and colonoscopy was done. So really, she had the works. We did repeat her CT and the PET scan, and we showed that we saw that there was that nonspecific nodule with hyperactivity on the initial PET later grew to be a larger lesion. So this was very suspicious for a primary site of malignancy. We actually consulted pulmonology, and she underwent a endobronchial biopsy. So this lady has gone through so many different tests, and in the end, the bronchial biopsy showed no neoplasm. There were just findings of reactive tissue only. So here's where the molecular information helps us. We did see that, this came back a little bit later, but we were able to see certain specific pathogenic mutations in KRAS, STK11, and TP53. And these are actually reported to be associated with non-small cell lung cancer. So in this case, it really led to a more definitive diagnosis. In this recent paper highlights how even our information currently about these mutations, we're still just learning about subgrouping them and whether the combination of KRAS along with TP53 or other combinations may have implications in terms of therapy. So especially in this paper, they talk about the presence, our particular patient's combination of molecular markers shows a sensitivity to PDL1 from increased PDL1 expression being associated with this phenotype. So in our testing, we also saw that she did have increased PDL1 expression of high expression and had a high intensity score. She had 14 mutations per base pair. And based on that paper I showed you, they talked about how this particular mutation in this focus was a biomarker that predicts benefit with anti-PDL1. In our tumor board, we then recommended that she undergo use of immunotherapy with checkpoint inhibition, and we will be putting her on Keytruda. So this is a real live case recently in the hospital. I think it goes to show where we are with how these tools can be useful. And I think it also points out some of the gaps still left remaining when you actually enter into a clinical scenario. Despite lack of the histological diagnosis or clear primary cancer at this point, some of these genetic alterations indicated that this was a non-small cell lung cancer and led to a therapeutic intervention for this patient. However, it also raises a number of questions in this particular case, given the patient's complicated history of multiple sclerosis, and whether use of immunotherapy could activate the multiple sclerosis. And that's still a black hole where there's very limited data. Or if the patient's use of immunosuppression from her MS, because she's now on Aubagio, another anti-MS therapy, whether that would counteract or interact with Keytruda. So I think it just raises a lot of questions for us, and I just bring that for our discussion.
So have you started treatment yet?
She's going to be starting next week.
I guess we'll know.
Yeah. You should have waited another month for this conference. I'll show you some pictures. Yes?
In your studies, the genetic markers are very helpful in the diagnosis. Why don't you start with that rather than subject the patient to all of the other procedures?
That's a good question. I think all of this is happening at once. Sometimes there is a little delay in getting the sequencing information back. And in this time period, there could already be progression of brain mets and clinical worsening. So we are trying to, while we are waiting for more information, continue our clinical workup, because it takes this much information to really understand it. And if we didn't have the PET scan, for example, having this information still would be missing the other corroborating factors to really understand the case.
So what's the immune therapy, what's the MS therapy more about?
She's getting Aubagio. She was previously on Tysabri.
And I can't remember the mechanism of Aubagio. Do you remember?
I know that Aubagio, we discussed this in our neurology conference, Aubagio does have some effects on T cells, and so that makes me a little concerned that there will be some interaction. But when I looked into the literature, I found a case series of 14 patients. They were therapy agnostic into point of view of MS preventive drugs that they were on, but they followed them once they were given Keytruda for their cancer diagnosis, and they saw that there were 7 of those 14 that relapsed. And 2 of those patients of the 14 had a fatal or very severe relapse that was medically refractory after the Keytruda or nivolumab. So that raises some questions. Thank you.